Hello, everybody. Good evening and good morning. Today we are having another great portion of knowledge, and today we have a great guest with us, and it's Kevin. Kevin is a clinical pharmacist. He's originally from Australia, but he's working at CHIO in Canada. And before we start, I would like to tell you that we are running on the YouTube channel. We are running on a Facebook and also on the Pharmacy College website, where you can just directly watch our webinar. So today we are going to talk about pharmacogenomics, but before that, we would like to thank you to the Pharmacy Without Borders Canada and also to Dr. Regis Vaillancourt for allowing us to do this webinar with all of you. Hopefully you will find a great piece of knowledge. First of all, we're going to talk about pharmacogenomics. We explain this very modern and new concept of pharmacy. We're going to talk about how the genes can influence drugs metabolism. This is very interesting, and we'll just give you some general guidelines, and hopefully you will enjoy it. So Kevin, please introduce yourself to our audience today, please.
Hi, everyone. My name is Kevin Chung, and as you said, I am a pharmacist at the Children's Hospital of Eastern Ontario. Just from a little correction, I am from Canada. I did my pharmacy schooling in the States. However, I did decide to come back home. And I am currently working for a company or a group called the Canadian Pharmacogenomics Network for Drug Safety, and I will go into a little bit about what we do during the presentation as well.
Great stuff. So I think we can start the presentation today.
Perfect. Can you see my screen yet?
Yeah, it's perfectly fine now. Excellent.
Okay, perfect. So I'll get started. So as I said, my name is Kevin Chung, and I'm working at the Children's Hospital of Eastern Ontario under the direction of Dr. Regis Vaillancourt, as well as for the Canadian Pharmacogenomics Network for Drug Safety, and that would be under Dr. Bruce Carleton. And today I'll be going over something pretty novel. It's an overview of something called pharmacogenomics, which I hope you will find pretty interesting. But a little bit about what I work for. CPNDS is essentially a multidisciplinary team based at academic health centers across Canada. And we are coordinated through the National Research Hub at the University of British Columbia. Now, we put a big emphasis on reducing adverse drug reactions. Many children experience ADRs or adverse drug reactions, and they are the 5th leading cause of death in North America and cost between $30 to $130 billion per year in medical costs. So, you know, in addition to saving lives and reducing permanent disability, there is a huge economic incentive in there as well. Essentially, we help solve drug safety problems by developing these genetic tests that predict which patients are at risk for serious adverse drug reactions. Our research entails collecting patient DNA samples, conducting a genetic analysis, and comparing the gene profiles of patients who have experienced an adverse reaction to those who were on the same medication who did not experience any reaction. So I'd like to preface this with a little bit of a story. As you can see here, you can see that there's a class action for infants whose moms took Tylenol 3, which is a combination of Tylenol and codeine. And this one mentions how codeine use while breastfeeding may be dangerous. So I'd like to say that in addition to clinical factors such as weight and age, genomic factors can also play a major role in drug response. Genomic variation can contribute to a large amount of adverse drug reactions by disrupting normal drug metabolism and transport in the body. So as I said, I'm going to tell you a little bit of a story. There was this newborn infant. The mother had an unremarkable pregnancy and delivery. However, by the 7th day, this infant developed difficulty breathing, as well as becoming increasingly lethargic as well. By 11 days, he was taken to his pediatrician with concerns of changes in his skin color, as well as decreased milk intake. And by day 13, this infant was found cyanotic and without vital signs. So they did a post-mortem toxicologic test, which found a morphine blood concentration of 70 nanograms per milliliter, and this is our usual range here, as you can tell. So it was a pretty high level there. So what happened was the mother was prescribed Tylenol 3 after a procedure. She was initially taking 2 tablets twice a day, but reduced this down to 1 tablet twice a day due to somnolence and constipation. Following the development of poor neonatal feeding, she actually expressed her milk and stored it in the freezer, and they were able to analyze this milk, which revealed a morphine concentration of 87 nanograms per mil. Now, the mother was found to be an ultra-rapid metabolizer of the enzyme CYP2D6, and this was her genotype here. And this probably looks like gibberish to a lot of you right now, but hopefully by the end of this presentation, we can have a better understanding of what this means. So my objectives today are to define pharmacogenomics and other relevant genetic terms. We will review how genetic variability can lead to individual differences in drug response. I will describe the goal of personalized and precision medicine and pharmacogenomics. We will review pharmacogenomic guidelines and resources, the clinical applications of pharmacogenomics, as well as the role of the pharmacist in regards to pharmacogenomics. Now, medication is personal, so everyone is different. You and I are not the same, and our differences can translate into how we each respond to drugs. So you may get questions in your pharmacy like, why does this drug work for him but not for me? Or why does she experience side effects and I don't? Or why do I need twice the standard dose for this drug to be effective? And that kind of falls into where precision medicine comes in. Precision medicine is essentially the approach to disease treatment and prevention that considers individual variability in genes, environment, and lifestyle. And this image here kind of draws into what I just spoke about. So you have a cohort of patients here who are getting this drug. And let's say for an example, this drug is clopidogrel. Sorry. And basically, so what happens here is that we have our patients who are experiencing effective cure. So clopidogrel is an antiplatelet drug usually used for preventing myocardial infarctions or strokes. So they're experiencing a good antiplatelet effect here and experiencing no thrombotic events. The second cohort here is having no effect, or the non-effectiveness cohort, or our non-responders. And these patients are not experiencing any effective antiplatelet effect and therefore may experience a thrombotic or ischemic event such as a stroke during clopidogrel therapy. And then we have our third cohort here, which is our severe side effect cohort. They may be getting an effective antiplatelet effect. However, that effect may be too strong and they're experiencing heightened side effects such as a major hemorrhage. So that kind of ties everything together there. So I'm just going to do a quick review on genetics. We have a lot of terminology that I'm going to go over. So we have our genome. This is essentially the organism's complete set of DNA, which includes all of its genes, regulatory elements, and other nucleotide sequences. And we can kind of think of this like a book. So we have DNA, which is deoxyribonucleic acid, which is the chemical name for a molecule that carries the genetic instructions. We have our chromosomes, which is a single piece of DNA containing many genes. And you can think of a chromosome kind of like the chapters within a book. And then we have our genes, which is the basic physical unit of inheritance. So basically, these are a sequence of nucleotides in DNA or RNA that encode for RNA or a protein. And then finally, we have our nucleotides, and these are our bases or the building blocks of DNA. And basically, there are 4 nucleotides that make up DNA: adenine, cytosine, guanine, and thymine. So you can think of the gene kind of like a sentence, and then the nucleotides are basically the alphabet within those sentences. Now, we have an allele, and that is basically just the version of a gene. So for most genes, a patient will have 2 copies of an allele, one maternal, so from your mom, and then one paternal allele from your dad. And then you'll see this word a lot, polymorphisms, and that's basically just a variation within a gene. The most common type of polymorphism is a single nucleotide polymorphism, or a SNP, and you'll be seeing that throughout this presentation a lot as well. Sorry. So next we have our genotype, which is an individual's collection of genes. This can also refer to the alleles inherited for a particular gene. we have a phenotype, which is basically the observable physical characteristics expressed from your genotype, such as blue eyes, enzyme activity, or brown hair. And the predicted phenotype is determined by the functional activity of each inherited allele. So you can be heterozygous or homozygous for certain genes. So if you're heterozygous, you'll have 2 different alleles inherited for that specific gene, whereas if you are homozygous, you'll have 2 identical alleles inherited for that specific gene. And this image here kind of just draws into that. So you get DNA from your mother and your father, and that makes up your genome here, as you can see. And then that is expressed as your phenotype, so height, eye color, or disease. Now, there is a difference between pharmacogenetics and pharmacogenomics. Pharmacogenetics being how the study of the relationships between variations in a single gene and the variability in drug disposition, response, and toxicity, whereas pharmacogenomics is the study of the relationship between variations in a collection of genes, which can be up to the whole genome, and variability in drug disposition, response, and toxicity. So in summary, basically genetics is how a single gene affects how we respond to a drug, whereas genomics is much more of a broader blanket term and is how all genes or our whole genome can influence a response to a drug. Oops, sorry about this. So the next thing we have is genetic variation. So essentially the human genome consists of roughly 3 billion base pairs with 20,000 to 30,000 genes. Genomes of 2 unrelated individuals differ by 0.1 to 0.5%, which doesn't seem like a lot, but this can be 3 to 5 million base pairs. So there's a lot of variance there, as you can tell. A genetic variant is the specific region of the genome which differs between 2 genomes. So for polymorphism, this is a genetic variant that is common or in more than 1% of the population, whereas a genetic mutation is a genetic variant that is rare or found in less than 1% of the population. So essentially, a mutation is defined as any change in a DNA sequence that is away from normal, implying that there is a normal allele that is prevalent in the population, and that mutation changes this to a rare and abnormal variant. In contrast, a polymorphism is a sequence and variation that is common in the population. Next, we have our genetic variants again. So I'll talk about some different types of genetic variants again. We have our single nucleotide variants, which is the difference in one nucleotide in the DNA sequence. So you have your single nucleotide polymorphisms, as I mentioned earlier, and these are basically just common single nucleotide variants. And these variants account for approximately 90% of variation in the human genome. So there's 2 different types of SNVs. We have our synonymous SNVs, and essentially this does not affect the protein sequence. So you can see here this thymine was changed into a cytosine. However, the protein does result in the same amino acid. This is because most amino acids have several RNA codons that translate into that same particular amino acid, whereas you have your non-synonymous SNVs. So in this case, this cytosine is changed into a guanine, but this results either into a different amino acid, which is called a missense mutation, or you can have one that codes for a premature stop codon, which would end up in a nonsense mutation, which usually ends up in a useless protein or enzyme in that case. You have copy number variation. So this is a type of structural variation and is basically either a duplication, as you can see here, or a deletion of a region of a DNA sequence, which is usually more than 1,000 base pairs. Many CYP2D6 gene variants are due to copy number variation, deletions, duplications, or multiplications, and has also been recognized that some cancers are associated with elevated copy numbers of particular genes as well. These are just some other forms of variation. I don't really have the time to go over those today. However, if you are interested, you can look them up yourself as well. And next, I will go into what genetic influence a variation can influence. So we have pharmacokinetics, which is basically how our body affects how we process drugs. So you have your drug metabolizing enzymes, such as your cytochrome P450 system, which includes CYP2C9, 2D6, and 2C19, and I've listed some medications here that are metabolized by those enzymes. And you have your phase 2 enzymes, such as TPMT and G6PD as well. You also have drug transporters, such as SLCO1B1, which is essentially used to transport certain things such as simvastatin into hepatocytes for elimination. And then we have pharmacodynamics, which is how drugs affect our body. So there are certain drug targets such as VKORC1 with warfarin, as well as some human leukocyte antigens, which are associated with hypersensitivity reactions with these medications. And I will go over these later as well. So this image here kind of ties into what I was just talking about. So you have your drug metabolizing enzymes and your drug transporters affecting pharmacokinetics, as well as drug targets affecting your pharmacodynamics. Now, drug transporters can sometimes be the drug target, so they can also affect pharmacodynamics. And then this dotted line here basically means that drug metabolizing enzymes are also sometimes a drug target affecting pharmacodynamics, but this all leads to variability in efficacy or toxicity. So again, these are just some common mutations that you may see out there. So basically G6PD metabolizes respiricase. However, if you have a G6PD deficiency and you're taking respiricase, you can end up with something called hemolytic anemia. Hemolytic anemia can also be caused if you eat something called a fava bean and you have a G6PD deficiency. That can also lead to hemolytic anemia as well. With CYP2D6, these are some substrates of that, so codeine, tamoxifen, as well as some selective serotonin reuptake inhibitors such as paroxetine and fluvoxamine. CYP2C19 metabolizes clopidogrel, some other SSRIs such as escitalopram, and then some proton pump inhibitors such as omeprazole. CYP2C9 metabolizes warfarin. And then we have these HLA variants here. So HLA-A3101 can be associated with carbamazepine-induced hypersensitivity. HLA-B 5701 can be associated with abacavir-induced hypersensitivity reactions as well.
Kevin, so I would like to just ask you. So it looks like these medicines that are very well known and they are very commonly dispensed.
Yeah.
And there's a large volume of them dispensed, and it means basically that before we didn't know the pharmacogenomics. Now basically we can understand that not only like bioavailability is important, but also the genes can influence the drug metabolism.
That's
and,
right.
and how we feel after these medicines. And these medicines, they're treating serious problems. They treat pain, they treat depression, cancer. They make the blood thinner, basically. So they use as anticoagulants after stroke or atrial fibrillation, epilepsy as well. And it means that basically the treatment is much better for those patients when we include in the treatment the concept of the metabolism, genetic metabolism, and the genes responsible for this. Yeah. So it looks very impressive. Very impressive.
Yes, exactly. And I will go over some things later about what we're trying to do to basically implement pharmacogenomics into the healthcare system. But I have some slides for that later as well.
Excellent.
Perfect.
Okay, let's carry on.
All right. So our next slide, we'll go into drug metabolism and pharmacogenomics first. So we have our cytochrome P450 enzymes here. So those are our phase 1 enzymes. And then we have our methyltransferases and N-acetyltransferases, as well as some other enzymes here that are part of our phase 2 enzymes there. So I will first go into something called CYP star notation. So you can see this little example that I have down here, but essentially every allele is given a star notation. So we have our star 1 or star 4, and then each star notation is given to a specific variant. The reference allele is called the wild type allele and is denoted as star 1, such as this one right here. And these SNPs are numbered sequentially as they are discovered. So CYP2D6 makes up a small portion of the cytochrome P450 system in the liver. However, it metabolizes 25 to 30% of all clinically available drugs. And then I've listed some substrates here again, such as codeine, antidepressants, some antipsychotics, as well as tamoxifen. And this next image here is an example of CYP2D6 allele function. So you have your normal functioning alleles, which are noted as star 1, star 2, star 27, etc. And then you go into your decreased function alleles, such as star 9, star 10. And then you have your no function alleles, such as star 3, star 4, and star 5. And then that leads into phenotype nomenclature for our drug metabolizing enzymes. Keep in mind, these may vary between enzymes. It's not universal. However, for CYP2D6, you'll have your ultra rapid metabolizers, your extensive metabolizers, or your normal metabolizers. you'll have your intermediate metabolizers, and then you'll have your poor metabolizers. So this is just an example of a genotype result. So for CYP2D6, you have your wild type allele here, and then you have a no functional allele here. And then this little star, this little number in brackets here means that there are 2 copies of this gene. So if you remember back earlier when I talked about copy number variants, or basically what happens is that there are extra copies of this enzyme floating around in the body, so you'll have more of it. And then we'll go into CYP2D6 phenotypes. So you have your ultra rapid metabolizers. So that's an individual carrying a duplication of normal functioning alleles. So you have your star one, and then the N is denoting that there are multiple copies of them. You have your extensive or your normal metabolizers, which is an individual carrying either 2 normal function alleles or 2 decreased function alleles, or 1 normal function allele and 1 decreased or no function allele. And there are some examples to the right here. And then you have your intermediate metabolizers, which is an individual carrying 1 decreased function allele and 1 no function allele. And then finally, you have your poor metabolizers, which is an individual carrying 2 no function alleles, as seen here. So this is just the global distribution of ultra rapid metabolizers for codeine, or just CYP2D6. So North Africa has the highest frequency at 40%. You can go down to America, which is around 8%, Europe being 3%, and then South Asia, Central and East Asia being around 2%. So we could go back to our CYP2D6 patient case example that I went to in the beginning, but this is just going to be a little bit different. Basically, you have a patient who is unresponsive, and with the history of present illness, AB is a 3-year-old male who is 25 kilograms post-adenotonsillectomy 1 day ago, and his past medical history is significant for recurrent tonsillitis. He was prescribed codeine 8 milligrams every 4 to 6 hours and had 6 doses in the past 24 hours. His post-serum mortem serum morphine concentration was 17.6 nanograms per mil, and the therapeutic range is around 4.5 nanograms per mil. There were no other medications detected, and his CYP2D6 genotype was star 1, star 2 with 3 copies. So without looking at the next slide, I was wondering if anyone could tell me what they would think is happening here. I don't know if they're able to talk pure or if you're able to just echo what they are typing.
Yeah, I'm just at the moment we don't have any questions, but we can just carry on basically. But it's very interesting. And by the way, I have to tell you that we're also going to start this project in Poland. We already applied for the grant. Actually, we are going to do it with Professor Carlton as well. So we're thinking about pediatric patients and also with patients with the depression. And we just basically apply for the grant. So hopefully, very soon we'll receive the funding, and we'll try to do our Polish part. And,
yeah, no, that's great to
we
hear.
want to match it with the Canadian experience and see how it works. But yeah. I believe it's going to be the future of pharmacy anyway. It's
I agree too. It's very interesting, and it's definitely very changing. It's going to change the
medical field. A lot of money as well, because the adverse drug reactions. It's patient satisfaction from the treatment, so they don't get a good quality of life. But also, it means that if there's no quality of life with treatment, they don't take medicines. If they don't take medicines, they basically create a great expenditure for the healthcare system.
Exactly.
So, unfortunately, it works this way. So
yeah, cool. You got it. That's exactly right.
Yeah.
So basically, what's happening? If you remember back to pharmacology, codeine is a prodrug, meaning that it needs to be metabolized in the body to its active metabolite, which is morphine, in order for it to exhibit its analgesic effect. So it is metabolized by CYP2D6. So if you remember my story at the beginning, the mother was an ultra-rapid metabolizer of CYP2D6, hence why she felt tired and constipated all the time while she was on the codeine. And morphine is also passed in through the breast milk to the child, so that's why the child had such high serum concentrations of morphine as well. So if we move on, our patient was, again, an ultra-rapid metabolizer of CYP2D6, as you can see here. So therefore, what does that mean for prescribing? So let's start with the first one left here. So you have a CYP2D6 poor metabolizer. Therefore, you would want to avoid codeine in this patient because the patient's not going to be receiving any analgesic effect due to the poor metabolizer status of CYP2D6. For a patient who has an ultra rapid metabolizer status, you would also want to avoid codeine because they would have extra levels of morphine in their body, therefore increasing their risk of CNS depression and respiratory depression as well. Actually, what happened in 2013 was the FDA introduced a black box warning with codeine, which essentially contraindicates the prescribing of codeine in children post-tonsillectomy and adenoidectomy. Codeine is really not recommended in any children less than 2 years of age, but there's also risks in neonates and young children who are ultra rapid metabolizers as well. And as you know, codeine and its metabolites are secreted into breast milk. So I probably want to avoid giving any mother who is breastfeeding codeine just because we probably don't know what type of metabolizer they are. So at CHEO, I work at an outpatient pharmacy as well called the Kid Care Pharmacy, and we get a lot of prescriptions for post-surgical patients. And today is actually my 1-year anniversary at CHEO, but I have never seen a single codeine prescription at my time here. We typically see morphine or hydromorphone just because there's a much more predictable pharmacokinetic profile to them. So these are some more drugs with metabolism-based pharmacogenomic information and FDA labeling. Some that I didn't go over, such as atomoxetine, is metabolized by CYP2D6, as well as fluoxetine, a popular selective serotonin inhibitor. Clopidogrel is metabolized by CYP2C19. This is also a prodrug as well. And then we have warfarin, which is metabolized by CYP2C9. And then you get into your phase 2 metabolism, which is azathioprine and 6-phenylcaptopurine, which are metabolized by thiopurine S-methyltransferase. You have rifampin that is metabolized by an acetyltransferase, and then irinotecan, which is metabolized by uridine diphosphate glucuronol transferase 1A1. So we'll get into some other phenotype nomenclature. We'll first have our drug transporters and our non-drug metabolizing enzymes. So these can be characterized as having increased function, normal function, decreased function, and poor function. And then you can also have carrier status for certain gene variants, such as the human leukocyte antigen. So you can be positive or negative for these variants. So we'll go into drug transporter pharmacogenomics. Essentially, there are variants in drug transporter genes, which can lead to a decrease or increase in the transportation of drugs, affecting the pharmacokinetics and or the pharmacodynamics of these drugs. Now, there are two families of drug transporters. We have our ATP binding cassette transporters, such as P-glycoprotein, which is responsible for cellular efflux. And then we have our solute carrier transporters, such as the OATP1B1, which is responsible for cellular uptake. This is also known as SLCO1B1. So we'll go into an example here of SLCO1B1. Essentially, SLCO1B1 gene provides the instructions for making a protein called the organic anion transporting polypeptide 1B1, also known as OATP1B1. Just to get rid of any confusion, this can also be known as the SLCO1B1 transporter. And essentially, this protein is found in liver cells, and it transports compounds from the blood into the liver so that they can be cleared from the body. Now, one of these compounds is statins, such as simvastatin. So the SLCO1B1C 521C allele results in a decrease in simvastatin uptake into the liver and can result in increased concentrations of simvastatin in the body, increasing the risk of concentration-dependent simvastatin myopathy. Now, these SLCO1B1 alleles are categorized based on function. So you have your normal transporter function alleles, such as STAR1A and STAR1B, and then you have your decreased function alleles, such as STAR5, STAR15, and STAR17. And then I have a little bit of a chart here kind of describing what the phenotypes are. So you have your normal functional phenotypes, and these are individuals carrying two normal function alleles, such as STAR1A, or STAR1A, STAR1B. And then you have your intermediate function phenotype, which is an individual carrying one normal function allele plus one decreased function allele, such as star 1a, star 5, or star 1a, star 15. And then you have your low functioning phenotypes, which is an individual carrying two decreased functioning alleles, such as star 5, or star 5, star 17. So this image here kind of illustrates everything that I was just talking about. So you have a simvastatin in your intestinal cell here. And typically what happens is the SLCO1B1 is responsible for transporting that into the hepatocytes where it is metabolized and then cleared from the body. However, if you have a less functional SLCO1B1 transporter, then you'll have more concentration of simvastatin in these cells and in the body, therefore increasing your risk of muscle toxicity. And then next we have our drug target pharmacogenomics. So there are certain characteristics of these drug target pharmacogenomics. They're polygenic, meaning that there is a bunch of these proteins that can influence drug response, such as receptors, enzymes, and ion channels. Polymorphisms have pretty subtle effects on the protein function, and they lack distinct phenotypes, meaning that the measurement of phenotypes is very variable and imprecise. So I'll talk about the human leukocyte antigen, which is part of the major histocompatibility complex. And the major histocompatibility complex basically comprises the genes for human leukocyte antigen class 1 and 2. And these HLA molecules are encoded by the HLA genes that play a crucial role in the immune system. Essentially what they do is they bind to endogenous and exogenous peptides that result from the breakdown of self-cells or foreign proteins, and they present these bound peptide antigens to T cells to initiate their antigen-specific responses. So sometimes these antigens are recognized as self, and in some instances, these antigens are recognized as non-self, and you will have any immune response. So this kind of shows what I just spoke to you about here. So you have this keratinocyte holding on to this HLA-B5801 variant attached to this allopurinol peptide complex. And this T cell here will recognize this little complex here as a non-self and exhibit a immune reaction. So what I'm saying here is HLAs basically present drugs to the immune system, and some HLA variants are associated with drug-induced immune reactions, which can range from mild to severe and lethal. So let's talk about allopurinol and HLA-B5801. This can lead to something called SCAR, which is also known as an allopurinol hypersensitivity syndrome. And this is essentially manifested by things such as Stevens-Johnson syndrome, as well as toxic epidermal necrolysis, and is associated with systemic signs that may include fever, hepatitis, and acute renal failure. There's pretty substantial evidence out there that HLA-B5801 is linked to allopurinol-induced SCAR. This was first identified in the Taiwan Han Chinese population, where HLA-B5801 was present in 100% of patients with allopurinol-induced SCAR, as compared to only 15% of allopurinol-tolerant controls and 20% of the population controls. So that gets us into our recommendations. So if you are a non-carrier of HLA-B5801, then you are at a low or reduced risk of allopurinol-induced SCAR, and therefore you can use allopurinol per standard dosing guidelines. Whereas if you are a carrier of HLA-B5801, then you are at a significantly increased risk of allopurinol-induced SCAR, and therefore allopurinol would be contraindicated. These are some other drugs that are affected by HLA variants. So you have carbamazepine and oxcarbazepine, drugs that are typically used for epilepsy and seizures. So if you are a carrier of the HLA-B1502 allele, then you are at risk for Stevens-Johnson syndrome, as well as toxic epidermal necrolysis if you are on these medications. And then if you are a carrier for HLA-A3101, then you are at risk for maculopapular exanthema. Abacavir, a common antiviral medication used for the treatment of HIV. If you are a carrier of the HLA-B5701 allele or variant, then you are at risk for a hypersensitivity reaction if you are taking this medication. So these are some other examples with drug target pharmacogenomic information, FDA-approved labeling. As you can see here, you have abacavir and carbamazepine there. Some other interesting ones, you have warfarin, which basically inhibits this vitamin K epoxide reductase, which is a drug target. So genetic variants in the VKOR-C1 gene results in decreased VKOR expression and is associated with decreased warfarin dose requirements in that case. Another one is ivacaftor here. So this is a drug that's used for the treatment of cystic fibrosis, which is basically a result of genetic variants in the cystic fibrosis transmembrane conductance regulator, or the CFTR gene, which essentially results in abnormal CFTR function. So ivacaftor is a CFTR potentiator and is indicated for cystic fibrosis patients with specific mutations in the CFTR gene. So we'll next go over some pharmacogenomic resources. The first one is PharmGKB, which can be found at www.pharmgkb.org. Basically, this was formed in the year of 2000 to be a comprehensive online resource that collects, curates, and disseminates knowledge about the impact of human genetic variation on drug responses. Essentially, this can be used as a resource to independently research genetic variation and its effect on medication response. So on PharmGKB, you'll find pharmacogenomic prescribing information that includes dosing guidelines for how to adjust treatment of a certain medication based on a person's genetic information. It contains these medication labels that contain pharmacogenomic information, and then clinical annotations that summarize all of PharmGKB's annotations of published evidence for the relationship between a particular gene variant and a medication. And this is kind of what PharmGKB looks like here. So for codeine on the left, you'll have like pharmacogenomic prescribing information, its drug labels, as well as clinical annotations. And then in the search bar up here, you can search for drugs, genes, or a combination of both. Now, I don't really use PharmGKB all too much. I much prefer CPIC, or the Clinical Pharmacogenetics Implementation Consortium, which can be found at cpicpgx.org. This was formed in 2009 to provide international consensus guidelines on pharmacogenomics that are actionable, peer-reviewed, and evidence-based, as well as freely available. And basically, CPIC guidelines are designed to help clinicians understand how available genetic test results can be used to optimize drug therapy. And there's currently 25 CPIC guidelines available. So this is an example of what a CPIC guideline kind of looks like. This one is for CYP2C19 and clopidogrel therapy. So in these guidelines, you'll find summaries about the genes. So you'll find summaries about CYP2C19 and then its phenotypes. It'll tell you about genetic test interpretation, as well as genetic test options. It'll give you therapeutic recommendations and also tell you about other considerations, such as risks and benefits for the patient. So you may have seen this circle before, you may have not, but essentially this is the pharmacist care process. And the big question to ask is, where does pharmacogenomics really fall within this circle? Now, it can be a pretty subjective question, but to me, I believe that pharmacogenomics falls throughout this little process here. As pharmacists, we see our patients more than they see their doctors. So we're able to collect a lot of information, asking patients whether their medication is working for them or not, or if they're experiencing any side effects. And from then on, we can see if they're appropriate for pharmacogenomic testing. And then we're also there to assess those test results if we deem that they are eligible for that. So if we find that they are eligible, we get the test results back. We can then develop a plan to optimize therapy, and we can go through that plan with their prescribing physician, as well as implementing that plan. And then, as I said, we are there to see our patients more often than they see their physicians. So we can be there to follow up, monitor, and evaluate as well. And we can start that process over again.
Yeah, Kevin, we have a question.
Sure.
Edita is asking how testing of the patient looks like. What kind of materials are examined? Is the blood test enough, or defined as Drig's experience of drug reactions? I think
so.
As a blood is a different way.
There's a couple of type of tests that you can do. What I'm typically used to is either that you can do a saliva test or a blood test. I know like there's these free, or not free, but you can pay for these certain DNA tests online called like 23andMe and Ancestry as well. And I believe those collect saliva testing from you as well. Does that answer your question?
I think so, definitely, Edita. Does it answer your questions? Yeah, hopefully she will come back to us in a moment. And do you do this test in the pharmacy?
So It's something that we're trying to implement at the moment. Typically, right now, it's done through studies for the most part. I do know in the States, I believe they have implemented pharmacogenomic testing throughout pharmacies actually. So they're a little bit ahead of us in that regard.
Mm-hmm. Cool, thank you. So let's carry on with the presentation.
Okay. So a couple of types of pharmacogenomic testing we have preemptive testing, which is essentially genetic testing before it is needed and is stored for future use. And this is nice because genetic testing results are readily available and can be included immediately in any medical decision making. We have our reactive testing, which is testing genetic testing as a medication is prescribed. So in this case, you're only genotyping for certain variants that you need. You have your single gene / few variants, which is genotyping to a gene or variants to a medication of interest. And then we have our multi-gene or variants paneling, which is genotyping many variants, not particularly directed towards a medication of interest. So a doctor comes up to you and says, hey, I'm thinking of testing one of my patients. Well, we're at CHIO. We did something in collaboration with the Canadian Pharmacogenomics Network for Drug Safety called the Genomics Application Partnership Program Study. This is essentially was there to bridge the gap between the science of pharmacogenomics and its integration into healthcare by providing a tool for the clinical uptake of pharmacogenomic information. So basically, we were there to determine the clinical utility and feasibility of implementing pharmacogenomic testing into clinical practice. We then, after examined the views of both family and prescribing physicians after testing was done, and from that we developed these 3 pharmacogenomic panels. We have an analgesic panel, an infectious disease panel, as well as a mental health and neurology panel. I wasn't around for this study. I came into CPNDS after this study was completed. However, what I'm doing at the moment is I'm trying to implement pharmacogenomic outpatient testing into the pharmacy that we have upstairs. Basically, pharmacists in a community setting will inquire if a medication is working or not, or if their patients are experiencing any adverse effects, and if they can deem it necessary to contact their physician for pharmacogenetic testing in order to optimize therapy. So this is an example of a gap study report. So you'd have your sample ID here and then your sample type here. So we use saliva for this patient, ancestry if they told us what it was, and then their requested panel was a mental health panel, which consisted of these genes. So we have 2C9, 2C19, and 2D6. And then these are the results that came about. So for 2C9, we found that this patient was an intermediate metabolizer with the STAR1 and STAR2 alleles. They were a rapid metabolizer of CYP2C119 with the STAR1 and STAR17 allele. And then for 2D6, they were a normal or extensive metabolizer as described by this activity score here. So for our results, we had 136 patients enroll. Patients and physicians both participated in these post-test questionnaires, and overall feedback was positive for most patients and physicians. Most patients were not aware that there was a genetic test readily available to predict adverse event risk or medication efficacy. They found the results easy to understand and thought they were well presented, and felt that it was important to know the risk of adverse reactions and would recommend testing to a friend or a family member. For the physicians, they thought that the information was organized in a logical order and was well presented while being visually appealing. Their main complaint was that there was not enough information to make a clinical decision. They felt that a lot of these panels were small and felt that there was only partial information given, and there were medications from some class that they really had no information on. They also felt that some of these results took way too long to obtain as well. These here are just little spiels that I collected from some of the interviews. One physician really appreciated the in-depth review of their patient's medication history. They were very impressed that someone was able to take the time to review their patient's chart and felt that it was a personalized test, not simply just a lab test. Another physician found that having pharmacogenomic testing results was incredibly helpful for those challenging patients that have already been on multiple medications. The test provided extremely valuable information about the next steps and also provided a hope to these families that are struggling, along with providing a sense of hope to their beleaguered clinicians as well. So this is the analgesic panel that we developed. So as you can see, it's mainly opioids. For choline and hydrocodone, those were associated with therapeutic failure or an increased risk of central nervous system depression. And then for oxycodone and tramadol, there was an increased risk of central nervous system depression as well. This was our infectious disease panel. So we had our aminoglycoside antibiotics such as tobramycin or gentamicin, which were associated with hearing loss or deafness. Isoniazid was associated with serious liver injury. And then our sulfonamide antibiotics, dapsone, nitrofurantoin, norfloxacin, and some antimalarials were associated with G6PD deficiency-induced hemolytic anemia.
Kevin, we have a question. How long do we have to wait for the results?
It really depends, right? And we're trying to streamline it, but really the main limiting factor is collecting the results, sending them off to where they're being tested for, and then having those results sent back to you. So really, what we're trying to do is have it within a week or 2 weeks. But that all obviously relies on everything working properly, like a well-oiled machine. Does that answer the question?
Absolutely. Yeah.
Perfect. So finally, we had our mental health and neurology panel. So we had our anxiety and depression medications here, which are mainly SSRIs. And these were associated with either therapeutic failure or an increased risk of adverse effects. We had our neurology panel, which consisted of carbamazepine and phenytoin. So if you remember back to my HLA talk, these were associated with life-threatening skin reactions. And then finally, we had our ADHD panel, which only consisted of atomoxetine. So it's a very small panel, and this is one of the main complaints of the physicians, was that there was not enough information given. But this medication was associated with therapeutic failure or increased risk of adverse effects. So I will end off my presentation with a bit of a patient case to tie everything together. So a patient comes in to pick up their medications. She is currently taking citalopram and has been on this medication for 3 months now. You prompt the patient by asking them if their medication is working well for them. They say that their medication isn't doing very much for them and they still feel constantly anxious. So do you guys think pharmacogenomic testing would be appropriate for this patient? It's a pretty rhetorical question, in my opinion. Obviously the answer is going to be yes. However, we can think about it logically, right? So this patient has been on this medication for 3 months now, and it's an SSRI. And typically SSRIs take between 4 to 6 weeks to really reach their heightened or their peak effectiveness. So they're well past that. And what we could do is we could just send them back to their doctor, and their doctor could prescribe them a brand new SSRI. But that's more of a hit or miss situation, and that SSRI may not work. So if we do pharmacogenomic testing, we can have a much clearer picture of what to do in that case. So our patient is on citalopram, which is metabolized by CYP2C19, and I've listed some other medications here as well, which are metabolized by either CYP2C19 or other enzymes here in the cytochrome P450 system. And so your pharmacogenomic tests were returned 1 week later, and you find that your patient had the following genotypes/phenotypes. So as we can see here, she is an ultra-rapid metabolizer of CYP2C19. Therefore, she's metabolizing her citalopram way too fast for it to be effective. That being said, with these newfound results, what would your recommendations be? So what you could do here is essentially you could just go to the CPIC guidelines that I have here for 2C19, and it shows that if any patient is a CYP2C19 ultra-rapid metabolizer, you would therefore want to consider an alternative drug that is not predominantly metabolized by CYP2C19. Now, CPIC also has guidelines for CYP2D6. Our patient was an extensive metabolizer or a normal metabolizer, so you can essentially start her on any of the medications that were there for CYP2D6. And avoid any medications that are metabolized by CYP2C19. You could look at duloxetine. However, you see here that she is a rapid metabolizer of 182 as well, so you would probably want to avoid that. So you could start with fluvoxamine, paroxetine, as well as venlafaxine or vortioxetine. And that concludes the end of my presentation. I thank you guys for having me for this presentation here, and I was wondering if you guys now have any questions for me.
I think Kevin, it was a very great explanation, and I'll just give you a bit of background because recently in Poland we are trying to deploy new services, and we are obviously at the beginning of our way in Poland to do more clinical work as well. And this was extremely advanced for the type of practice we have in Poland because we mainly sort of focus on selling boxes, unfortunately, and take a charge from the patient. That's all. Even patient counseling is quite bad at the moment. So this was extremely advanced, but I wanted to actually show because to other interested people, many students, because we had a very good meeting yesterday at the Ministry of Health with the students' organizations, and we're talking about the necessity of changing the education program. And I just wanted to show because I didn't get the straight feedback basically if they really are happy to change the program or if they think that it's necessary. But I wanted to show them with today's presentation that actually if you want to be on this level, it's like sort of like Elon Musk is now traveling to Mars. Yeah, it's really a long way in front of us. But I just wanted all the young people to know that how far behind we are. So this is extremely advanced project, and I'm actually happy that University of British Columbia invited me to do this project in Poland.
That's really good to hear. Actually, Bruce is a great guy. I mean, the stuff he's doing is really important. So
great stuff. I'm so happy, and we created already a team of people who just deliver this project here in Poland. So hopefully we'll get some good results. But obviously it's for the future. It's just to build up the confidence that pharmacists can do something extra. But the main thing is the quality of life of patients.
That's right.
Exactly. You don't have to suffer. I mean, in some ways, for instance, it's like sort of like giving grapefruit juice to the patient who is taking therapy. And this particular way is going to be extremely happy because I'm not sure if you know, but if you give the grapefruit juice to people taking sildenafil, it will work better, basically, So you can even save the money instead of giving just give them a 50 milligram sildenafil plus give additional a bit of grapefruit juice. He would perform very well and he'll be very happy. But obviously it's slightly more advanced. I mean, the concept is the same, to make them happy, but in a different way.
That's right, exactly.
So the concept is really interesting. I will have a question. If patient is tested, does her test result available for his doctor automatically?
We're still trying to figure that out, but essentially our idea is it's all done through an outpatient system through a third party group. So we're sending off those results to them, and then the results are returned to the pharmacist, and the pharmacist can then kind of analyze and assess those results, and then the pharmacist will then go over those results with the physician. So if that's the case, then no, it's not going to be automatically available anywhere for the doctor. The pharmacy will get it first, and then the pharmacist will then create a plan with the doctor and kind of try to implement that plan for their patient.
So you have to explain the doctor why you recommend to change the
exactly. That's right.
Yeah. So it's sort of evidence-based, and you just show the guidelines. You guide the doctor through why it should be changed, like the citalopram case. I think it was very, very interesting. I think the background is extremely difficult, but I think finally the process, the service is quite not as difficult as we think it is.
No, exactly. We're trying to get it started. Hopefully by the new year we'll be able to get it implemented and going, and we can see how successful it is from there on out. Obviously there is a cost to testing, so there's an economic incentive as well, right? But we're hoping that our patients have insurance that can cover this, or they can find a means of getting a way to pay for it as well.
But eventually it will go down. The price will go down anyway because it's a little volume of production. The more you produce, it's cheaper.
Yeah.
So it's like a face mask during the COVID, like they're going cheaper now. It's everywhere. It's plenty, So before there was a problem, there was none. So if there's none, it's expensive. So I think that's the way. So I think it was a great journey to the new way that pharmacy can be perceived, and also it was a good time, a good hour to show you that pharmacy is a very advanced profession, and we're just at the beginning of this way. So our main purpose for this workshops basically every Wednesday is to show you something completely different, and that's why we also change, because we can deliver even better knowledge that is not available here in Poland. So Kevin, thank you very much for doing that. It was great.
Yeah, my pleasure, of course.
Thank you so much, and I would like to obviously thank you to the Pharmacy Without Borders and Dr. Regis Vaillancourt for helping us to organize this meeting. It's extremely valuable, and I think all the pharmacists, I can see that they are impressed. So thank you very much for these comments. So I'm glad that you are with us, and hopefully see you next week. Next week we're going to talk about Medicine News Review, the first step in Medicine News Review, and also give some additional highlights about Polish projects. So please watch us next week. And
I look forward to it, Piotr.
Yeah, thank you so much, Kevin.
Yeah, thank you so much. Bye, everyone.
Thank you
so much.
Bye-bye.
Bye.
Bye.